Welcome, team, to Morning Rounds. For today's explainer, we're hitting the wards to tackle a massive, absolute heavyweight of a topic, intrinsic acute kidney injury. Now, you know the drill. When we evaluate AKI, we generally split our differential into three big buckets, right? Pre-renal, intrinsic, and post-renal. Pre-renal is all about perfusion, post-renal is about obstruction. But today we're hyper-focusing on that middle bucket. This is where the actual structural integrity of the renal parenchyma is compromised. We're going to make this interactive, so definitely get your clinical thinking caps on.
Okay, let's dive right into our patient census for the morning. We've got 4 beds to visit today. Bed 1 is the microvasculature, Bed 2 is the interstitium, Bed 3 covers exogenous toxins, and Bed 4 is endogenous toxins before we wrap it all up with a final synthesis. Let's hit the floor.
All right, first up, Bed 1, the microvasculature. We're looking at diseases of large vessels and the microvasculature.
Here's your first clinical scenario. We've got a 65-year-old patient, day 3 post-angiography. We're suddenly seeing an acute decline in their GFR. The patient spiked a fever, their labs show eosinophilia, and on physical exam, you notice this mottled, purplish skin discoloration on their legs, classic levo reticularis. So team, what is the exact source of the injury here? I want you to really think about it for a second and lock in your diagnosis.
The answer is atherosclerotic disease. Great job if you caught that. See, when instruments like catheters are advanced through the aorta, they can literally scrape against the vessel walls. This disrupts those fragile, cholesterol-laden plaques. Tiny cholesterol fragments break off, shower down into the smaller renal arteries, and just get trapped. And what's super fascinating here is that the clinical picture presents almost exactly like an inflammatory vasculitis.
Let's move to the next step and see exactly how this builds. Step 1, the aortic instrumentation physically disrupts the plaque. Step 2, those little fragments embolize and get wedged in the renal microvasculature. Step 3, the body recognizes this junk and mounts a furious, intense inflammatory response. Honestly, this is exactly why you see systemic signs like fevers and eosinophilia. And finally, Step 4, this massive inflammation and physical occlusion cause severe tissue ischemia, which can rapidly snowball into acute tubular necrosis. Okay, moving right down the hall to Bed 2, the interstitium. We're talking acute interstitial nephritis, or AIN.
All right, team, I'm going to put you on the spot again with a classic word question. A patient presents with AIN. In clinical practice, how do we actually differentiate AIN triggered by NSAIDs from AIN triggered by antibiotics? And I mean just based on their clinical signs and what we'd see on a biopsy. Take a moment to think through those key differences.
Let's see if you are on the right track. For antibiotic-associated AIN, think penicillins or cephalosporins. You typically see those classic systemic allergic signs. You know, the fever, the rash, and on a biopsy, you'll find a high frequency of eosinophils. But for NSAID-related AIN, like with standard ibuprofen, those systemic allergic signs are usually totally absent. And if you check the biopsy, lymphocytes actually tend to predominate in the interstitial infiltrate, not eosinophils. Definitely keep that distinction in mind. It's a super helpful clinical pearl for the wards.
Now, before we leave Bed 2, we really have to talk about the modern era of oncology. Our AIN differential is rapidly expanding because of checkpoint inhibitors, drugs like nivolumab. Now, these drugs are absolutely brilliant. They disable a cancer cell's ability to evade T cells by blocking specific proteins like PD-1 or CTLA-4. But by doing so, they cause a loss of immune self-tolerance, so the immune system basically gets hyperactivated and inadvertently attacks the kidney's tubular interstitium, causing a really severe autoimmune AIN.
Let's keep moving. Bed 3, exogenous toxins. We're looking at iatrogenic tubular disease. Okay, here's your next patient case. A patient with pre-existing chronic kidney disease is sent down for a CT scan with iodinated radiocontrast. Shortly after, they develop AKI. Team, what happens to the fractional excretion of sodium, or FeNA, in this specific type of injury compared to almost all other intrinsic tubular injuries? Think about the lab values here. What exactly happens to the FeNA?
The FeNA is classically less than 1%. Now, why is that weird? Well, most intrinsic injuries, like classic ATN, result in sodium wasting because those damaged tubules just can't reabsorb sodium anymore. So the FeNA is usually greater than 2%. But radiocontrast uniquely causes profound vasoconstriction and altered microcirculation right alongside that tubular toxicity. So it presents with urinary sodium retention, On the labs, it actually looks like a pre-renal state, even though it is very much an intrinsic injury.
Let's evaluate the patient right next door. This patient has a severe gram-negative infection and absolutely requires an aminoglycoside, specifically gentamicin. We all know it's nephrotoxic, but team, let's get down to the molecular level. Why does gentamicin accumulate specifically and toxically in the proximal tubule? Dig deep and recall the mechanism for me.
So the crucial point here is the maglin and cubolin complex. This is an endocytic receptor complex located right on the apical brush border of the proximal tubular cells. Aminoglycosides have these cationic, positively charged amino groups that basically bind perfectly to this complex. It's like a lock and key. The cell essentially swallows the drug via endocytosis, traffics it inside, and once there, it disrupts ATP production and triggers mitochondrial apoptosis.
Because we know exactly how toxic this pathway can be, you always need to screen the chart before prescribing. What are the risk factors that make this maglin-cubolin pathway even more dangerous? We're looking at prolonged therapy, high or repeated doses, any pre-existing CKD, volume depletion, diabetes mellitus, and advanced age. If your patient has these, you need to be incredibly vigilant with your dosing and monitoring. No exceptions.
While we're on the topic of antibiotics, let's talk about vancomycin. I have a quick bit of medical history for you. When vancomycin was first approved way back in the 1950s, it was actually nicknamed Mississippi Mud. Why? Well, because the early formulations were literally brown and just full of impurities. For decades, we blamed those impurities for its high rates of nephrotoxicity. But here's the catch. Modern vancomycin is highly purified, yet we still see AKI. Why is that?
Now, what's really interesting about this is that modern purified vancomycin directly causes obstructive tubular casts. If a patient gets high doses, especially more than 4 grams a day, or if it's mixed with piperacillin tazobactam, aka Zosyn, the vancomycin molecules actually bind with uromodulin in the tubules. They form these non-crystalline, nanospheric aggregates. It literally physically clogs the pipes. It's a fascinating, recently proven mechanism of injury that we didn't fully understand until recently.
All right, let's move to our final clinical stop, bed 4 endogenous toxins, specifically myoglobin and immunoglobulin light chains. Here is your patient at bed 4. We've got a 22-year-old male admitted with severe rhabdomyolysis after a crush injury. His urinalysis is strongly positive for blood. It's heme positive, but under the microscope, there are absolutely 0 red blood cells. We know myoglobin is choking the kidneys. But fellows, what is the exact chemical reaction that myoglobin triggers to destroy the tubules at a cellular level? Think back to your pathology and biochemistry days for this one.
It is the Haber-Weiss or Fenton reaction. Here is the step-by-step pathophysiology. First, the heme from myoglobin is taken up by our old friends, the maglin and cubolin receptors. Second, once inside the cell, it liberates free ferrous iron. Third, that free iron acts as an intermediate accelerator for the Fenton reaction. And fourth, this reaction violently generates hydroxyl-free radicals. This leads to severe oxidative stress and lipid peroxidation that just shreds the cell membrane. The free iron literally becomes a cellular weapon.
Okay, last patient question of our rounds. We have a 60-year-old female newly diagnosed with multiple myeloma. She is producing massive amounts of excess free light chains, or FLCs. Team, how do these FLCs cause both direct tubule toxicity and cast nephropathy? Think about it. These are 2 totally distinct pathologies caused by one single endogenous toxin. How does the location in the nephron dictate the injury? Think it through.
And this brilliantly illustrates the segmented nature of the nephron. In the proximal tubule, you get direct toxicity. The FLCs are endocytosed via maglin, they accumulate in the lysosomes, generate hydrogen peroxide, and activate the inflammatory NF-kB pathway, basically destroying the cells from the inside. But once that proximal capacity is totally overwhelmed, the FLCs wash down into the distal tubule. Here they encounter TAM-horsefall protein. The FLCs bind directly to it via their CDR3 domain, co-precipitating to form massive hard casts that physically obstruct urine flow. 1 toxin, 2 deadly mechanisms. Great job on rounds today, team. Let's do a quick final synthesis. The future of intrinsic AKI.
I really want to leave you with this final, provocative thought. For decades, we thought acute tubular necrosis was just accidental, passive cell death from injury. But modern science has revealed that much of this cell death is actually highly regulated by genetic pathways. We're talking about iron-dependent ferroptosis or receptor-mediated necroptosis. If this death is programmed, well, that means it can be unprogrammed.
Could the future of nephrology lie in targeted inhibitors, like ferrostatins, to simply switch off the death pathways and finally cure intrinsic AKI? Keep an eye on the literature team, because the way we treat these patients is about to revolutionize. Thanks for joining me on Rounds, keep studying, and I will see you on the next explainer.